This is on. There we go. Good afternoon, everyone. Thanks for being here. Really appreciate the opportunity to kind of go over some of the data that we have on CurvaFix. Some of it is early. You'll see some case reports as well. We're going to go do this relatively rapid fire. So this paper just recently was published in JOEI, was presented here in a video format last year at OTA. It's the early postoperative outcomes of a 3-center experience. And so from a background perspective, I think we all know and kind of heard if you were at the pelvic and acetabular session that there are issues with non-operative treatment, particularly prolonged immobilization and length of stay in terms of the hospital. There are also concerns with ORIF. There are risks associated with surgery. But with percutaneous fixation, we've been able to do more with minimal incisions, less risk of complications, less soft tissue dissection, and often better recovery for the patients. We also know that pelvis is complex 3D structure, right? It's not a nice, simple tibial long bone or femoral long bone where you have a cylinder and you're putting another cylinder down a simple cylinder. This anatomy is complex. It's curvilinear, and trying to match that anatomy can be challenging, particularly with nonlinear, with traditional straight screws. And so the curved implants allow for fixation around these osseous pathways that many of you have seen. And there's different fixation strategies that you have to think about as well, depending on where the injury is. And again, we heard some great sessions upstairs just a little bit ago about fixing the front and the back, particularly in some of these geriatric fractures, and in fact, fixing some of these geriatric fractures. And so different fixation strategies exist, and you can use the CurvaFix for posterior ring fixation, as you can see here. This is a great example. You can see the S1 tunnel. You can see the wire going around the S1 tunnel, so the S1 tunnel is protected, and you can see the curved wire followed by the curved screw, and the tunnels are safe the entire time. You can also do column fixation. This is an elderly person who's having difficulty mobilizing, and again, the ability to put an anterior column screw as well as a posterior column screw in an antegrade fashion to protect the columns and allow early mobilization is beneficial. So in our study, so again, 3 centers, multi-center retrospective study, 111 patients amongst all 3 places. All the patients were made weight-bearing as tolerated. This is our early experience. As we've moved on, a larger percentage of our patients are weight-bearing as tolerated, but in this case, 81% of them were made immediate weight-bearing as tolerated. And at the most recent follow-up, which was at least 3 months for these patients, 50%, almost 50% were ambulating unassisted. The complication rate was quite low, less than 10%. 4 had intraoperative complications, including a malpositioned implant, a broken implant, and 1 bladder rupture. And then there were routine postoperative complications such as nerve palsies, wound breakdown, and infections. Again, this is the early experience with this implant. These are the first cases that we did amongst the 3 centers, so you can expect a little bit of a learning curve. So in conclusion, curved intermedullary implants are safe to use. They're a minimally invasive alternative treatment strategy, especially in curved corridors, and the early results suggest that immediate weight bearing does not lead to loss of fixation and allows for good healing. Thank you.